we had just started talking about the vertebral column and the vertebrae in particular. So just to review that, the basic anatomy that all the vertebrae share in common, we'll look at this again. And then what we'll see after that is we're going to look at the cervical vertebrae, the thoracic vertebrae, and the lumbar vertebrae, because you need to know the differences so you can identify one from the other, particularly in lab. All right. So all vertebrae have these parts. They have a vertebral body, which is kind of, it can be either round or oval in the lumbar, or even kind of heart-shaped in the thoracic vertebrae, but it's always broad and flat when you look at the vertebra from the top. The articular processes stick out here. You know, you can think of the vertebra as kind of a cross, while the articular processes come out between the ends of the cross there. And then the vertebral arch, which is this right here, is made up of these parts. So we've got the spinous process that sticks out directly towards the back. You know, so this is the front of the body, this is the back. The transverse processes either stick out to the side, or in the thoracic lumbar, or the thoracic vertebrae, they actually kind of stick out at a 45-degree angle, which I'll show you more here in a minute. And then the pedicles are here and here, and that's where the vertebral arch, which is this structure right here, actually attaches to the vertebral body. Because it's through this vertebral foramen that the arch makes, that's where the spinal cord runs. You know, so one of the purposes of the spinal column is to protect that very delicate spinal cord that goes along inside it. So the pedicles attach to the vertebral body, and then the lamina attach the left and right sides together, and the lamina kind of join together in that spinous process. So the lamina, together with the pedicles and the vertebral body, make up that vertebral foramen, or the vertebral arch. All right. When we stack the vertebrae together, we can kind of see their three-dimensional shape. So even though we see pictures like this a lot, it's important to note that vertebrae are not flat. You know, if you set them on a table, they're going to have another dimension to them. So you can see this vertebrae right here continues down. So this is all one piece here. The one below it also continues down. And like I said last time, the easiest way to see this arrangement is to look at the column of vertebrae that we have in lab. So you can see how the one above kind of reaches below to attach to the next vertebra down in the chain. Where the vertebra come together, either with the ribs or with other vertebrae, we call those articular facets. And articulation is just a joint, or a place where two bones come together. So an articular facet is a smooth spot. Facet means smooth. So it's a smooth spot where bones come together. And we'll see that in the thoracic vertebrae, not only do the vertebrae connect to each other, but they also connect to the rib cage that then goes around towards the front. All right. So starting at the top, remember we have 7 cervical vertebrae. And some easy to identify features. These are probably the easiest to see. So in the cervical spine, the transverse process, which sticks out to the side, there are these 2 holes in it, one on the left, one on the right. Inside this hole is where the vertebral artery runs. And the vertebral artery is one of the primary arteries that supplies the brain. So we only see these holes in the cervical vertebrae, so C1 through C7. So that stands out. We call that the transverse foramen, and inside of there is the vertebral artery. The vertebral body in the cervical spine is small. You know, when we see the lumbar vertebrae, the body of the lumbar vertebrae is probably bigger than this whole piece. The reason for that is as you go down the spinal cord, the vertebral bodies have to get bigger because each one is carrying more weight than the one above it. You know, the cervical spine really only has to support the weight of the head. By the time you get to the lumbar spine, you know, you're supporting half the weight of the body. So those vertebral bodies have to get bigger to carry that extra weight. So in the cervical spine, the vertebral bodies are small and oval in a kind of transverse way. So they sit long and flat along the back there. And then another easy to spot difference is in the spinous process. The cervical spine, it's bifid. In other words, it's split. It makes a little tiny V at the top. Now, the cervical spines, you can't really feel those in your own neck because of all the muscles that are present there. But when we look at the cervical spine bone, we see this little split here. So it's easy to identify. It's only the cervical spine has that V-shaped or bifid spinous process. All right. So those are the cervicals. When you see them in lab, you'll see that they're kind of small and delicate. You know, the cervical spine has a lot of motion, so we can move our heads in all kinds of different directions. And part of that is because the cervical spine or the cervical vertebrae are small and light, so that they move very easily. Now, the first two cervical vertebrae have special names and a kind of unique anatomy. So we call them the atlas and the axis. So what we're looking at here is this is C1, and then underneath it, this is C2. And on the atlas, or C1, you see these broad, flat plates on the top. This is where the skull sits. So we call them the atlas and the axis because, you know, in the Greek story of Atlas, the character, he holds up the world, right? You know, Atlas holds up the world. Well, the atlas vertebrae holds up the head. So the skull connects to the atlas, or C1. And because of these broad, flat facets here, it allows us to flex and extend our head. So the reason that we can shake our heads yes is because the skull literally slides on these on the facets of the atlas. So the atlas holds up the head, accounts for the yes motion, the nodding of the head. Now the next one down, the C2, is called the axis, and an axis is a pin or a center, a thing that allows something to spin. And the C2 has an axis. We call it the dens. So sticking up from the vertebral body of C2 is this little bony knob. And that bony knob attaches to the atlas in a way that C1 can turn on C2. So the reason we can shake our heads no is because the atlas turns on the axis, allowing the skull to turn on C2. So it gives our head that rotation that allows us to look left and look right. So the atlas and the axis have this unique arrangement. Now, while the flexibility here is good, anytime a thing is flexible, it also means that it's weaker. So one of the reasons we pay particular attention to neck injuries, like after a car accident or trauma, is this dens can actually snap off. Now, if that occurs, there is now no bony connection between C1 and C2. So in theory, you could sever the spinal cord by moving that C1 across the vertebral canal, and it would literally cut that spinal cord off. So one of the reasons we put people in backboards and we pay special attention to their neck is that this dens can actually break, and then we have a lot of instability there. So the atlas and the axis. And I've got a couple of really good models in lab of this system that lets you see how they move and how the skull kind of sits on top of it. But the first two get special names. And then the last one has a special feature. C7, or the seventh cervical vertebrae, it looks a little different than the others because its spinous process is very prominent. So if you run your fingers down the back of your neck, the first vertebrae that you can feel sticking out is C7. And we call this the vertebra prominens, or prominence. You know, so it's prominent. It's easy to see. Now, in attached to this vertebrae is a ligament called the ligamentum nuchae, which actually helps us to hold our heads up. It's easiest to see if we look at not a human model, but we'll draw a very simple dog. Okay. So we got some ears up here. I'm a terrible artist. Tongue hanging out.
Yeah, I thought the other end was the head.
That's the tail. That's the big bushy tail. You gotta have a big bushy tail, right? All right. So this would be that vertebra prominens, and there's a ligament that goes like this. And it works a little bit like a bowstring. So if you imagine a bow like a bow and arrow, if you take this shape right here, it looks, sort of the same way. And what this does is it allows us to hold our head up without having to use a lot of muscle strength. This tendon is very elastic. So once the dog lifts its head up and gets to this position, the elasticity sort of pulls on it and it holds the head up. Now for us humans, our heads are much more in line with our spine than our four-legged friends are. If you think about a dog, they're doing this all the time. They're looking straight from their perspective. But for us, we still have this ligamentum nuchae, and it still has this bowstring type arrangement that helps us to hold our heads up without muscles having to pull it up all the time. So attached to that vertebra prominens is that ligamentum nuchae. You see why I don't draw on the board? That's bad. But it's an interesting physical relationship. So when you go to pet your dog or cat, you can sometimes feel that ligament back there when they have their heads up. It's kind of stringy, like a bowstring. All right. So down into the thoracic spine. So we have 12 of these, 12 thoracic vertebrae. And their cardinal features are, when you look at them from the side, the spinous process points downward. And that's unique to the thoracic spine. The cervical spine kind of points directly backwards. The lumbar vertebrae also point directly backwards. But the spinous processes of the thorax point down. So they point at like a 45-degree angle down. Just like this is a 45-degree angle, you can also see that the transverse processes also come out at a 45-degree angle. So unlike the cervical vertebrae where they came straight out, we'll see straight out in the lumbar vertebrae. In the thoracic spine, they come up at an angle. So 45 degrees here, 45 degrees here. The spinous processes of the thorax are very thin and slim. So you can see this is, it tapers to a very narrow point. That's another cardinal facet of cardinal sign that it's a thoracic vertebrae there. And then the last one is the vertebral bodies of the thoracic spine are kind of heart-shaped. So instead of being oval this way, like the cervical spine, or oval this way, like the lumbar spine, here this has kind of this indentation here. It's kind of heart-shaped. Another feature of the thoracic spine is they have some additional facets because it's in the thorax that the ribs are going to attach to that spinal cord. So not only do the thoracic vertebrae have to match up with each other, they have to connect with the ribs that are then going to go around and towards the front as well. So thin process, 45-degree angle, transverse process, the spinous process angles down. The costal facets, costus is rib, so costal is of the ribs. And then that heart-shaped vertebral body. All right. And then the lumbar, the easiest thing to see about these is that they're big and heavy and durable. And the reason for that is in the human being, the lumbar spine has to support all the weight of the whole top half of the body. In our four-legged friends, we don't see that, because they distribute their weight to their forepaws and their back paws. But in the human, it all has to go through the lumbar spine. So the lumbar vertebrae are big and heavy. So you can see they're kind of tall from the side. Everything about them is kind of unelegant. They're blocky and coarse. Compare it to the thoracic spine where we have these nice sweeping angles and this nice thin spinous process. In the lumbar, everything's all, it's built for strength, not really for flexibility. So we have short, thick spinous processes. So here it is from the top, here it is from the bottom. You can see that it's just kind of big and clunky. The transverse processes stick directly out to the side at 90 degrees, so kind of like the cervical vertebrae, only much larger and heavier. And then we have this very large oval vertebral body for carrying weight. So the lumbar spine is not very flexible. You'll see that where the lumbar vertebrae come together, there is some motion. We can turn our lumbar spine, but not nearly as much as we can our thoracic and our cervical spine. Very much built for carrying weight. All right. And well, I can't really show you this in the slides, but size plays a role here too. The cervical vertebrae are only about that big, and the lumbar vertebrae are significantly larger. But when you get to lab and you see the three, you'll be able to identify those. So large vertebral body, short, stocky processes that stick directly out 90 degrees. All right. And then the vertebral column ends with the sacrum and the coccyx. I'm going to turn this front light off so we can see a little bit better. Now, when we're born, the sacrum is actually made up of multiple vertebrae. But when we reach puberty, all of those vertebrae fuse into this one big bone called the sacrum. Sacrum means shield. So you can imagine that, if you a shield for fighting, the sacrum sort of looks like that. It has that shape, and it also has a curvature to it, which it's hard to see in this picture, but here you can sort of see it. The sacrum comes around and it curves at the end. So it starts out straight and then curves. In males, the curve is much more pronounced than it is in females. So one of the ways that we can tell a male skeleton apart from a female skeleton is by the sacral curve. In men, it's almost like a 90-degree angle. It bends around and points forward. And in the female, it's a much less of a curve. Now, the reason for that is during childbirth, the baby has to sneak its way past this sacral curve. So it can't be curved in too much in the female, or it'll block the birth canal, which we'll talk about more when we get to the pelvic skeleton later on. And then at the very end is the coccyx. And this, too, starts out as multiple small vertebrae that fuse together. Now, if we had tails, this is where our tail would start. So it would attach to the end of the sacrum, and then the coccygeal vertebrae would stay separate so that the tail can move and bend like we see in our dogs and cats. Particularly cats have very flexible coccygeal vertebrae. That's why they can do all the neat tricks with their tail that they can. All right. So all of this detailed anatomy is not important to know. Just know that we start out with 5 sacral vertebrae, and then they fuse together. So follow that bone list that I gave you last time. All right. So to review the differences, and here you can see the difference in size. And even still, the difference in size is bigger than these pictures make it seem. But cervical, thoracic, lumbar. So cervical, we have our bifid spinous process. So if you see a V at the top, it's the cervical vertebrae. You have these big honking holes here in the transverse processes. That's the vertebral foramen, or the transverse foramen, where the vertebral artery runs. And then we can see this sort of oval-shaped and sort of small vertebral body. So that's cervical. In the lumbar, we have our long, thin spinous process that points down. So it points down towards the floor at about a 45-degree angle. The transverse processes come out in kind of a Y shape, so at 45 degrees instead of at 90 degrees like we see here and here. We have the heart-shaped vertebral body. And then in the lumbar spine, we have short, stocky processes that come straight out towards the back and towards the side. And then we have a great big heavy vertebral body for carrying weight. So this is a good slide to mark because you will get questions about telling vertebrae apart. So this is a nice summary of the differences between those. Now it gets a little trickier because as you go from cervical, from C1 all the way down to L5, there are subtle differences between each vertebrae too. But in general, the cervical, thoracic, and lumbar vertebrae all have these differences that make it possible to tell which vertebrae you're looking at. All right. Okay. So attached to the thoracic spine in the back are the ribs. And the rib cage, as we refer to it, is the ribs that come around from the side, and then there's the sternum in the middle. So the sternum in the middle has 3 parts. So this is the breastbone or the breastplate. The manubrium is up here at the top. The body is the long part that goes down through the middle. And then the xiphoid process is the little cartilaginous point at the end of the sternum. The xiphoid process is a very commonly used anatomic landmark. A landmark is something that you can see or feel from the outside that tells you the position of things on the inside. So like when we examine patients, we'll often use the xiphoid process as a kind of reference point to know where the end of the rib cage is in the front. So you can very easily palpate the xiphoid process. In some people, it kind of points anteriorly, so it angles anteriorly, and in some people it points towards the back. But in most people, it just kind of points straight down. So the sternum starts out as these 3 parts, but by adulthood, they fuse together. Now, the xiphoid process does still stay cartilage, but the body and the manubrium fuse together at this spot. There is a small amount of motion that's possible there, but it effectively becomes one bone. Okay. And then the ribs, we have 12 ribs, and we divide them up according to how they connect to the sternum. So the first 7 ribs, so that's rib 1 through rib 7, we call those true ribs. Now the fancy name is vertebrosternal ribs. And I'll get back to what the differences are here in a minute. Ribs 8 and 10, we call them false ribs or vertebrochondral ribs. And then ribs 11 and 12 are called floating ribs. Okay, so why do we use these different names? A true rib is one that connects to a vertebrae in the back and the sternum in the front. So not to another rib, a direct connection between the vertebrae in the back and the sternum in the front. So we can see that with 1 and 2 and 3 and 4 and 5 and 6. Okay, so here's the rib and here's its connection to the sternum. And then with number 7, here's the rib and here's its connection to the sternum. It doesn't directly connect, or it connects directly to the sternum. That's a true rib. So what about 8 and 9? Well, 8 comes around here, and instead of connecting directly to the sternum, it actually is connecting first to rib number 7. So its connection, because it doesn't actually touch the sternum, it gets to the xiphoid process. So that's true of 8 and 9, or rather 8, 9, and 10. And then 11 and 12 are interesting ribs because they don't come all the way around at all. We call them floating ribs because they don't connect to the sternum or the xiphoid process. We have these floating ribs in the back really to protect our kidneys. The kidneys sit back here underneath the diaphragm, so underneath the lungs. And 11 and 12 really are just sort of a shield for the kidneys that sit back there. So the floating ribs don't come all the way around at all. Now, some people have a 13th rib, and some people don't have rib 12. So there is variation in human beings in the rib cage, and that's one of them. So some people will have a lumbar rib that will come off of L1. All right, so manubrium, body, sternum, ribs. Okay. Ribs have very simple anatomy. I mean, their sole purpose is really to hold the chest open, which is important in how we breathe. You'll get to that next semester. And then protect the delicate stuff inside the thorax, so the heart and the lungs. So they have a thin shaft, they have a neck, and then they have articular facets, and we'll look at that anatomy in lab. Now, the ribs are actually flat bones. You know, the other flat bones we learned about were in the skull, right? Bones that form inside of a fibrous membrane. The ribs are also flat bones, so their look is a little different. And when we get to lab, you'll see that. They're very thin. They're quite flexible. It's actually kind of hard to break a rib because they'll bend before they'll break. typically the way you get a broken rib is either with a very quick blow where they don't have a chance to bend, they just simply break, or with a crushing force. You end up with a car on your chest, and it literally will squeeze the bones until they break. But ribs don't break very easily, and when they do break, they heal very quickly as well because they're flat bones and not long bones like we talked about last time. The way the bones connect to the vertebrae is kind of elegant. We have two facets that are a little ways apart on the rib, and the curve just kind of fits right there next to the transverse process. So in the thorax, the reason the transverse processes stick out like a Y instead of like a T is so they can follow that curve of the rib as it goes around. And you'll learn more about this in the respiratory chapter, but when we breathe, the ribs actually have to move. They don't stretch, they sort of rotate up and out, like we see here in this picture. We call it the bucket handle effect. If we take when we are exhaling, our ribs sort of sit like this. But when we take a breath in, just like this bucket handle lifts up and out as it comes around the bucket, the ribs do the same thing. So they expand the chest cavity forward and up and allow us to bring air in. So there has to be flexing here and here as well as at the sternum to make that happen. So the rib cage has to be flexible and somewhat mobile in order to make that breathing motion that we do happen. All right. So very simple. Ribs are very simple. But when they fit together, they do that remarkable thing. Okay, so we'll do our first question. Which of the following statements is true? Emailing that. All right, here we go. All right, jump in there, last few people. Okay, that's everybody. All right, so let's run the list. A, the first cervical vertebrae is called the axis. Note the axis is C2. C1 is the atlas. So the atlas holds up the skull, so it has to be the first one, because it's the one that touches the skull. And then the atlas sits on the dens of the axis and allows the skull to rotate. So C2 is the axis. The spinal cord protects the vertebral column. Got that backwards. It's the vertebral column that protects the spinal cord. The spinal cord runs through those vertebral foramen underneath the vertebral arches. Thoracic vertebrae have long, thin spinous processes. Yes, and that's unique to thoracic vertebrae. So it's a good way to identify that this is a thoracic, is they have these tapering, long, thin spinous processes that point downward. They point in a 45-degree angle down. The sacral vertebrae are actually inferior to the lumbar vertebrae. Remember, superior is towards the top, inferior is towards the bottom. It's saying nothing about the quality. It's not superior, inferior like that, just higher or lower. And then E, the lumbar vertebrae are usually they are the largest of the vertebrae, so they're larger than the thoracic or the cervical. All right. Where do we find transverse foramina? All right, so the transverse foramina, that's the fancy name for the big holes in the sides of the cervical vertebrae, where those vertebral arteries go through. Because technically, they are inside the transverse processes. Now, the transverse process in the cervical vertebrae are not very pronounced, but technically this whole thing here is the transverse process. So this is the transverse foramina. Foramina is just plural for foramen. Foramen is a hole. All right. Okay, so onward. So that's the axial skeleton. The skull, the vertebral column, the ribs, the sacrum, and the coccyx. So what we see here in yellow, that's the axial skeleton. Now the whole rest of the skeleton we consider the appendicular skeleton, or the skeleton of the appendages. So this is not appendix like the thing that can be removed from your intestine. This has to do with appendages instead. That's how it gets its name. So there are 126 bones in the appendicular skeleton. Most of those are going to be found, believe it or not, in your hands and feet. Because the hands and feet have so much dexterity, they have a lot of bones for their size. So most of these you'll see come in the distal part of the upper and lower extremity. All right. So we have a pectoral girdle and a pelvic girdle. A girdle is just something that holds something else. So the pectoral girdle attaches the arms to the axial skeleton. So we have 2 clavicles in the front. We have 2 scapula in the back. The scapula is an amazing bone for all of its flexibility, which I'll show you either today or next time. And then the scapula attaches to the humerus, so the upper arm bones. In the forearm are the radius and ulna. And then we get down into the wrist and hands, and you can see how the number of bones goes way up. So far, we've got 4, 6, 8, 10, but now there's 16 carpal bones, 8 on each side, so 8 on the left, 8 on the right. There's 10 metacarpals. The metacarpals make up the palm of the hand, and then the phalanges make up the fingers. So in the thumb, there's 2, and then in the fingers, there's 3, a proximal, a middle, and a distal. So you can see that, 38, so 54 of the bones of the upper extremity are found in the wrists and hands. And you'll see that same thing when we get down to the legs, too. For the lower extremity, we have the pelvic girdle is made up of 2 bones. Now, those 2 bones are made up of 3 bones, which we'll talk about later, that fuse as we develop. But in the end, as adults, we have 2 bones in the pelvic girdle. We have 2 femurs. We have 2 patellas, that's the kneecap. In the lower leg, we have the tibia and fibula, one on each side. And then here's that same pattern. We have a bunch of ankle bones, metatarsals, and phalanges. So tarsal bones are your ankle bones. There's 14 of those, 7 on each side. The metatarsals, that makes up the bulk of the foot. The metatarsals, too, there's 10 of those, 5 on each side. And then the phalanges make up the toes. So in the great toe or the big toe, there's 2, and then the rest of the toes, there's 3. So similar patterns. There's a lot of similarities between the arms and legs. Easy to understand why people believe in evolution when you look at the arms and legs and how they have virtually the same bone pattern. They just have specialized a little bit differently. All right. So we'll start at the top and work our way down. So the pectoral girdle attaches the upper extremity, which is our fancy name for the arm. Just to be clear, technically the arm only goes from your shoulder to your elbow. From your elbow to your wrist is the forearm. So in anatomy, we don't say arm, we say upper extremity, because that includes the arm, the forearm, the wrist, and the hand. We do the same thing with the leg, because technically the leg goes from your knee to your ankle, because from your hip to your knee, that's your thigh. So we have a thigh, a leg, a wrist, and a foot. So we call them the upper extremities and lower extremities. So the upper limbs attach to the trunk with the 4 bones, 2 clavicles, and 2 scapula. Now the human arm evolved for flexibility. We can move our upper extremity with a lot more range of motion than practically any animal except other primates. And one of the reasons for that is there's only one place where the arm attaches to the rest of the skeleton with a bone-to-bone attachment, and that is at the clavicle. So where the clavicle attaches to the sternum, that is the only bony connection of your arm to the rest of your body. Now, that's great for flexibility. It means we can reach all the way around and scratch our back on the other opposite side, and we can do all kinds of fancy things with our arm, but it's not greatest for strength. If we were still walking on all fours, we would have many, many injuries to our arms because of this weak connection. This is also the reason that the clavicle is the most commonly broken bone in the body. Because anytime you fall, what do? We put our hands out, right? Well, when you put your hands out, all that force of that fall is being transmitted into the rest of your skeleton. Well, the only place it can connect to the rest of your skeleton is at the clavicle. So very often clavicles will snap when somebody falls on an outstretched hand or falls on their hands, because all those forces are going right there into that one attachment of bone to bone for the arm. So we have a lot of flexibility in the arm, but it doesn't have a lot of strength. So you'll hear, and we'll talk more about this when we get to muscles, but rotator cuff injuries and clavicle fractures are very common because of this weakness in our arm. Lots of flexibility, not a lot of strength, not a lot of durability when it comes to forces coming up in and through it. All right. So for all its importance, the clavicle only connection to the skeleton for the rest of the arm, it's a really simple bone. It has this kind of S shape. It is also a flat bone, so it doesn't form like the humerus does or the femur does. It forms more like a skull bone does, which, just like the ribs, give it a kind of flexibility that allows it to bend without breaking. It has a sternal end. That's this side where it attaches to the sternum. It has this kind of S shape, and then it attaches to what's called the acromion process of the scapula here at the back. So it has an acromial end as well. The clavicle is one of the best healing bones in the body. On this one we got lucky. Here's the most commonly broken bone, but it also is a bone that heals most easily. We looked at some of the fractures, how they can become displaced. In other words, the two ends aren't lined up. For the clavicle, that doesn't really matter. This bone will get itself into the right position because of the muscles that surround it. So it's almost unheard of to need any kind of surgery for a clavicle fracture. The clavicle will line itself up and then heal. Yeah.
Is that kind of like the same thing for the ribs too?
Yes, ribs, same thing. They're held in place so well by muscles that you don't have to put them in line. They'll fix themselves, so to speak. Yeah. A good comparison. All right. So scapula is here in the back, clavicle. One way to think of the clavicle is it attaches the scapula to the sternum, because that's really what it's there for. All right. And then you get to the complicated one. So this is the scapula. Well worth spending some time on in lab, because the scapula is it's a complex three-dimensional bone. And you won't really get its anatomy until you hold it and look at it and turn it over in your hands. And also on our skeletons that we have in lab, look at how the scapula fits on the rest of the skeleton too. And you'll get a much better sense of what this bone is all about. So commonly we call this the shoulder blade, right? Now what we're actually talking about when we look at somebody's back and we see that the bones that sort of go up at an angle, this is what you're seeing, is this right here. So this is the scapula from the back. And what we call the shoulder blade is the spine of the scapula. And on the back, the spine of the scapula separates the upper part up here from the lower part down here. Okay? The spine goes up and forms what's called the acromion. The acromion is the tip of the shoulder. So if you find that bony spot that it's on the highest part of your shoulder, that's the acromion process of the scapula. And it is one of the places where the humerus attaches to the scapula. So we've got the spine of the scapula and the acromion. When we look at the front, we see that the acromion kind of curves up and over. See how it has this curvature to it? This is why these pictures don't do it justice, because you can see it much more easily than you have on your hand. But the acromion comes up, makes the top part of the shoulder. So on the upper part, just above the spinous, the spine here, so this is called the supraspinous fossa. Supra is over. Spinous means spine of the scapula. Fossa is just an indentation. And inside this supraspinous fossa is one of the muscles of the rotator cuff, called the supraspinatus, so it kind of matches its space name. But you will need to know that supraspinous fossa. On the lower side of the back of the scapula is another fossa. Here it's the infraspinous fossa. Infra means below. So we have a cavity above and a cavity below. Both of these have muscles of the rotator cuff that live in them. So the infraspinatus lives in here. The scapula has an angle at the bottom, so we have an inferior angle here, and then we have a superior angle, which is right up here. So we have a point here and a point here. Looking at the front of the scapula, and you have to remember, the front of the scapula is behind the rib cage in the back. So this is where you got to look at a skeleton. But you've got the rib cage, and then the scapula sits here. This is the front. This is the back, and we have this broad, flat fossa here, and that's the subscapular fossa. Sub means below, and if you started at the back of a person and you removed the scapula, that space underneath, so sub means below, so this is below the scapular fossa, so this is underneath the scapula. And here again, this whole region is taken up by a muscle of the rotator cuff called the subscapularis. Now, you're going to hear me talking a lot about the rotator cuff in a couple of different parts of this, in the joint chapter and in the muscle chapter. Just as a quick, what is it? The rotator cuff moves the humerus. It rotates it. So like this motion right here, the humerus itself is actually spinning. But its most important function is the rotator cuff holds the arm in place. If there isn't a good bony connection for arm to the rest of the body, clearly our arms don't just fall off on the floor all the time. And the reason for that is the rotator cuff is always holding and pulling the arm into its socket. So it's a set of 4 muscles that keep the head of the humerus firmly attached to the rest of the skeleton, notably to the scapula. All right. So subscapular fossa. There's this funny little finger-like projection here called the coracoid process. When you see this in lab, it looks just like a finger. It looks like this. And it is another site where the humerus attaches to the scapula. Coracoid means like a crow. Somebody thought this looked like a crow's beak, and it does look a little bit like a crow's beak. And then probably, the real business part of the scapula is this right here. The glenoid cavity is where the humerus, the ball part of the humerus, fits into the socket part of the scapula. And we'll talk a lot more about the shoulder joint when we get to our joints chapter. But for now, just know that the glenoid cavity, which is right here, is the ball for the ball and socket joint of the humerus. Okay, so it allows that humerus bone to move in all of its different directions.
You said that that's the ball part of it?
That's the socket part.
Okay.
The glenoid cavity is the socket. The humerus has the ball. Okay, so here's a little video. Because the scapula, it's hard to visualize, right? Because it's underneath the skin, and we don't see it move very often, but it has an enormous range of motion that gives our upper extremity all the crazy things we can do. We can reach around and scratch our back. We can reach around and touch the arm on the other side. And a lot of that is because of the scapula. So this is just how the scapula moves. So it slides up and down. That's abduction and abduction. Wait a minute, there should be more than that. Okay, here we go. Yeah, okay. So you can pull your shoulders forward, the scapula come forward, and they go out. So we have that sliding motion there. We can shrug our shoulders, so we can pull our scapula up, and we can push them down. They can slide up and out, like when you do a jumping jack. Literally, the scapula slide up so that we can touch our hands above our heads. And then we have that sliding down and sliding back. So before next time, think a little bit about your scapula and all the ways they move. So one of the things you can do is start with an arm at your side and go up here. And then anything above that, that's scapular motion. Because once you reach this point, the humerus can't actually go up anymore because it's blocked by bone. So when you raise your hands above your head, that's all scapula moving up and out. So those of you that are going into occupational therapy, you'll get very familiar with the shoulder because there's all these different motions that it can do. It is the most flexible joint in the body is the shoulder. All right. All right, we'll do one or two questions before we call it a day. Okay, the upper limb and its girdle are attached rather loosely to the rest of the body. What is true about that arrangement? Oh, there's two correct answers up there. Anybody see that? Pick one of the two correct answer. There is a best answer, though, which I'll talk about. All right, jump in there, last person. Okay, so the best answer here is C. It allows a wide range of movements. So what's the other potentially correct answer? D, you could say it restricts the amount of weight the upper limb can support. Well, not really, because we've all seen these Olympic weightlifters, right? Press huge amounts of weight. So clearly that can't be the case. So why is that? It's because weight is carried by muscle more than bone, particularly in the upper extremities. So, how can you walk? How can some people walk on their hands? Because it's the muscles that are doing all the work. So the limited skeletal connection gives a lot of flexibility, but the muscles make up for it in strength. All right, thank you, everybody. I will see you on Friday.